Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Justin Arner from Pittsburgh, Pennsylvania, United States. Dr. Arner is a double board certified orthopedic surgeon and sports medicine doctor in Pittsburgh, focusing on the surgical and non-surgical management of hip and knee injuries. Dr. Arner has specialized training and technical expertise in complex shoulder and elbow arthroscopy, shoulder instability, cartilage, and meniscal surgery. Dr. Arner completed his specialized training with a fellowship in sports medicine and shoulder surgery at the Stedman Philippon Clinic in Vail, Colorado. He completed his orthopedic surgery residency at the University of Pittsburgh and graduated medical school from West Virginia University as a member of the Alpha Omega Alpha Honor Medical Society. Graduating with the highest honors from Shepherd University in Shepherdstown, he was also a member of the Division II football team. An avid researcher, Dr. Arner has published over 100 research articles as well as 20 book chapters in national and international scientific presentations. He has been recognized nationally by the Avantgrade Health as one of the top 1% of orthopedic surgery researchers for 2024 and 2025. Dr. Arner is a monthly podcast host for the Arthroscopy Journal, which has the highest impact factor in orthopedic sports medicine. He's very active in journal reviewing for each of these high impact journals. And Dr. Arner is exclusively and extensively involved in multiple orthopedic societies as committee chair and member. So today is my great honor to introduce you Dr. Justin Arner from Pittsburgh. Over to you, Justin.
Thank you. Thank you, Professor. I appreciate the opportunity to speak with you and your audience today. We were speaking a little bit beforehand how exciting this is for you to be so selfless to put on this program. And I'm sure it's an extensive amount of work doing some podcasts myself and with video and sharing on YouTube. So we appreciate you educating us all around the world. So thanks for the opportunity here. So I wanted to talk about posterior shoulder instability. This has been the center of most of my research and what we know about in 2025. So I'm from the University of Pittsburgh in Pittsburgh, Pennsylvania, and I'd like to thank all of my mentors and colleagues for their help with all this research and work. So posterior shoulder instability historically was discussed mostly from an acute injury. That's really fairly uncommon, actually. It's less than 4% of shoulder dislocations. You know, we learn in residency about epilepsy and seizure, and when that shoulder is locked, like in this X-ray. Single traumatic event, so commonly, if you're a American football player, a lineman blocking, and you have your shoulder flexed and adducted and internally rotated, and you have that one event where that shoulder is pushed backwards and have a dislocation. But the more common circumstance, at least that we see, is a gradual repetitive injury rather than one single trauma from an epilepsy or a car accident or an injury. But commonly it's weightlifters or military people that are doing a whole lot of push-ups or overhead athletes. And historically, people would say that was 10 to 12% of shoulder instability. But more recent research, even from our group, shows that it's probably much more common. So it's cumulative microtrauma typically, and it's a repetitive injury in that same flexed and internally rotated position. So posterior shoulder instability is a little bit sometimes difficult to diagnose, and I think even in 2025 commonly missed, because instead of a frank shoulder dislocation like we see in anterior instability, where the shoulder comes out of place and someone has to pull it back in place, this is more commonly with pain and less commonly with instability. So people commonly don't remember one specific injury, but they can't return to their sport and they have pain, which is nicely outlined in Prevenger's article, which was an award-winning paper in HSM in 2019. So it's really a lot different than anterior instability, and we have to approach it differently. So again, the single traumatic event or repetitive microtrauma, again, military, American football linemen. In our NFL combine, we see it fairly commonly, actually. And that the image before was someone that is an NFL football player that I showed that MRI of. There's a different circumstance in overhead athletes. So instead of that traumatic repetitive trauma, it's the lead shoulder in golf or in baseball batters or backhand and racket sports. So basically, whenever that shoulder is thrown forward, it kind of slide out of the back. And more recently, we talk about throwers, and you can see in this image down at the bottom, we call it a lambda tear, a Y tear. Basically, it's a little different pathology rather than just being grossly posterior down below like the contact athletes. These throwers typically start with a tear up top, like with a slap tear. And then as that tear progresses, it can go down in what we call type 8 slap, or a combination of a type 2 slap that goes to a posterior tear. And then a split actually happens more laterally into the capsule, or more commonly into the labrum. And you kind of have this Y, which I'll show you some pictures of. So as I mentioned, these tears are much more common than we all typically thought. In some more recent studies over the last 4 or 5 years, this first study by Javier Duralde looked at 280 patients that had surgery, and 74% of those had some tear in the posterior labrum, with almost 50% of them being isolated posterior tears. In a study by Ben Kibler in 2021, found similar findings with a little smaller group. Isolated posterior was 26%, and almost 90% of them involved a posterior tear. In a group from our institution here with 1,700 patients, that 65% of them involved the posterior labrum. So, some of this is probably a little bit of selection bias. These are surgical patients, and these are physicians that are known for their posterior tears and their tertiary care centers. But certainly posterior labrum tears and repairs are more common than we thought. So as I mentioned here, more in pictorial form, this posterior directed force, either repetitive or acute, and then a more torsional rotation in these overhead athletes, where it starts up top and then rotates down. So again, posterior shoulder pain with axial load or force. These people, I commonly ask them, can you do push-ups, or do you have pain with bench press? And then the throwers, they typically will have pain with mid to late acceleration through release. They have control problems. They lose their velocity. Commonly, they miss high and outside, and they can't have that endurance that they desire because they lost that tension band. So here you can see that posterior labral tear, which is more classic tear from more of a repetitive micro trauma from, say, a football lineman in America. Or, here's that lambda tear, that Y tear that I was talking about. Here you have that posterior tear, but then as you go up higher, you see the slap tear, and then it splits again into the into the more mid-substance of the labrum, rather than being off the glenoid there. So physical examination, we're aware of this, but the posterior load and shift is what I think is really the most helpful to try to load that shoulder and click the shoulder out the back. Kim and jerk test, you can see here, I think these are all best used in combination. And then making sure that scapular dyskinesia isn't an issue with the winged scapula, or they have multidirectional instability with a positive Geigy sign, or positive sulcus that doesn't correct. So here are some other examples of exam findings that my partner, Jim Bradley, has really been the world expert on this posterior instability, and something that he's found to be helpful. So we call this the PIT 3-pack, which he utilized this dynamic posterior instability test, and he and John Conway kind of came up with this in Texas. But basically, you have your arm straight, like almost you're throwing a ball, and then the examiner puts their hand on the elbow, and then they push down. And those muscle forces kind of push that shoulder out the back. And then a modification, if you put your thumb or hand on the back of the shoulder to try to keep the shoulder in place, and their pain improves. And that gives us a good idea that this posterior, excuse me, instability may be an issue. And then the modified Whipple, excuse me, in the Whipple test, whenever you have your hand on the other shoulder and push your elbow up to the ceiling, and then the modification where you have that and on the back of the shoulder, and then you, Brian, or active compression test. Relocation maneuver also can be helpful here. We're not really sure why, but this is our study showing really high sensitivity and specificity with these tests. So initial x-rays to evaluate here are, we want to make sure the head is centered, that the glenoid version is too abnormal. We don't have significant glenoid dysplasia or glenoid bone loss, and making sure there's no reverse Hill-Sachs lesions. So making sure that's all normal is helpful. You can see that posterior glenoid dysplasia here in this x-ray. Here's a more evaluation on the MRI. We look at the same parameters, making sure there's no bone loss or that sloping posterior bone loss. And sometimes the labral tear is much less obvious. You can see on the left here, more like that Y tear, lambda tear, where there's two splits. And then this other one, if you're not looking closely, it can be easily missed, and commonly are missed with radiologists or other physicians whenever we're seeing them. Obviously we have the benefit of them, trialing other treatments, and then we can look closely at this MRI. And commonly there's a posterior instability history and episode here in MRI findings. So you can see those zoomed in here. So indications for surgery, we really want people to fail rehab. This isn't something that we are quite as aggressive about, say with a posterior shoulder, with an anterior shoulder dislocation and a big Hill-Sachs lesion. Commonly we do extensive non-operative treatments. If there's a big labral or flap tear that's flipped and the patient really can't do what they want, sometimes we move a little closer, more aggressively to surgery. And if people have significant posterior glenoid bone loss, as seen with one of our studies, over 11% people have a 10 times higher failure rate with surgery. So if you have posterior bone loss, we sometimes are more aggressive. And that also goes along with that glenoid that's a little more narrow at the bottom. Other concomitant injuries like a reverse haggle lesion or capsular rents. And again, if they can't get back to the activities and sports they want. So arthroscopy is really the gold standard. Debridement alone, I do that uncommonly. Typically, a labor repair with or without a capsular shift, depending on their goals and their sport. And, in some of these more lax patients, sometimes you can do capsulorrhaphy. It's really been shown by Prevention's group that a rotator interval closure is not very helpful, and just sutures are not as helpful as anchored repair. It's a little different topic than what we're talking about here. And thermal capsulorrhaphy should not be done. High failure rate and risks of osteoarthritis really have taken that out of favor. So some pearls with arthroscopy. I prefer the lateral position personally, but I really don't think it matters. Insufflating the joint, I think, is helpful with a spinal needle and a 60 cc syringe with whichever fluid of choice you desire. And I typically try to put that portal a little more lateral to try to get the position appropriate. Some of the curved guides, though, make this a little bit easier if you have a different angle, as you can kind of see in these images, and you can't get your drill guide. If it's a straight drill guide, you can't get the right angle, a safe angle to the glenoid. But some of the angle drill guides make that a little easier. One thing I think that's helpful is that if you have the wrong position, to take a switching stick and reposition it. It's better not to torture yourself to try to put a bad anchor in or some anchor that's going to be prominent. Just switch your angle here, and you can see how you can close the portal here with the PDS suture, and then you can reposition the desired angle. So if you're not in the right position, then you can switch it. So preparing the glenoid, as you can see here in the image, making sure you use a elevator. I personally think keeping the camera, first of all, in the posterior portal, and then using a more angled elevator from the anterior superior lateral portal gives you a better angle to elevate that across the glenoid. So knotless anchors, I think, are best. You don't have those suture knots sitting on the face, and knowing where you put the anchor is important. So inferiorly, as you can see in this top right picture, you put those anchors on the face because that's where the labrum lives. But in the superior labrum, if you're having to go up top with a type 8 slap, then you put those anchors off the glenoid face, so you're not over constraining the labrum. And shifting that capsule from south to north, and then I mentioned, closing that capsule at the end, I think is helpful, just so you don't have a hole back there, so it's not a stress riser to tearing. And then really looking at other things like reverse haggles, and again, the rotator interval doesn't need to be switched. But commonly the 7 o'clock portal, as you can see here in this picture, is further down and more central. I think that's really essential. Issuing the angles really are important here. I mentioned if you don't like your angle, then fix it. So that first switching stick was low, and this one you can reposition and you have a really better angle to attack the glenoid with the appropriate position. You can see pictures here that as well. So I think it's better just to spend the time and insufflate the shoulder. That's a helpful idea as well. So what are the risk factors for posterior instability? Brett Owens showed us for developing posterior instability that increased glenoid retroversion was an issue. With every 1 degree increase of glenoid retroversion, there was a 17% increase of repeat instability. And a study from our institution looked at 200 posterior repairs, and decreased glenoid bone width led to poor surgical outcomes, but not bone eversion. And then Tokish's group looked at return to full duty in American military folks, and if 13.5% bone loss was seen, which was 22% of patients, there was a decreased return to full duty, but the revision rates and outcomes didn't matter. So what else when we look at this more granularly in a big cohort in 2005 by Dr. Bradley, looking at 100 patients, they had good ASES scores and high return to sports level, which is reassuring. This is one of the landmark papers that really pushed people to think, make everyone realize that arthroscopy was the standard here. This is a study we did in 2013, which was 200 patients. Not all of these patients had anchors. It was before anchor repair was really determined to be the gold standard, and I think this paper helped establish that. But again, low rates of failure, 6.5%, high return to sport rates, and good to excellent outcomes. So anchor repair was better, and I think this is really an important study to show that. What about adolescents? When we looked at those patients, 110 patients, adolescents, basically reliable treatment for posterior instability. So they did well if they're younger as well. We broke up contact athletes. We had 117 of those, and again, good to excellent outcomes with ASES scores. When we looked at American football players, which were 70 patients, we had basically the highest satisfaction, the highest return to sport of any of the cohorts, probably because you can grab more of the capsule there. So you titrate your repair with a football player or a rugby player, you grab more capsule, and you can tighten the shoulder more significantly, which I think is helpful. In a thrower, you really don't want to grab any capsule because they're not going to be able to get in that position, and they're really going to have decreased ability to return to their sport, I think, if you grab too much capsule. And you can see that here in this paper, 70% return to sport with non-throwers at the same level and 60 with throwers. It's a little trickier. So the anchor repair did better, and you really don't want to grab capsule. What about long-term outcomes at minimum 10-year? We looked at 55 shoulders. There were 8 revisions. They all had significant improvements in ASES, pain score, stability. The KJOC was no difference in in throwers versus non-throwers. The issue is only 60% of patients were still involved in their sport at 10 years. People aren't playing American football or playing baseball once they graduate school and are moving on with their life. But basically, 89% of them said surgery was worthwhile, but the people were quite happy still at 10 years. I mentioned here some of those other concomitant pathologies where you can see splits in the capsule, suturing those back together. These are some nice pictures by Dr. Bradley's that he's come across in his years. So here's outcomes of revision repair. So just like, with an ACL or other surgeries, the first time around is really more reliable outcome. So 6.4% revision rate in 297 patients. And the risk factor for revision was female, being a dominant shoulder, having a rotator cuff injury, which was typically fraying, less than 3 anchors, and having a smaller glenoid bone width. So contact athletes, we looked at 186 of those, and the only issue we really saw there was smaller glenoid bone width. So version wasn't an issue, gender wasn't an issue. It was really bone width, and contact athletes again had the lowest revision rate, 5.9%. That was at 13-year follow-up. Throwers, they had a higher risk of revision at 8.2%, at 8.3 years. Again, don't grab too much capsule, put the anchor on the face, down low, put it off the face, up high. And these people's risk factors were female or having a lower pre-op ASES score. So what about the prevalence of bone loss? How common is it? So these are a few nice studies. One, AJSM 2018 is a military study. They noted that 42% of patients had glenoid bone loss posteriorly, and 22% had glenoid bone loss over 13.5%. So it's not uncommon. More recent study, 2023, showed 81% of patients had glenoid bone loss, and 23% had over 13.5 bone loss. And what were those risk factors? Athletes, dominant arm. It was not related to version or time to surgery from their injury. So really more active people in this study showed that they were more likely to have bone loss. So the bone loss is different than the anterior. So this is a nice study that was led by Dr. Preventure's group that I was involved in, as well as with Dr. Bradley. But basically 40 patients that were known to have bone loss on CT or MRI were evaluated. And the basically characterization of this bone loss was loss of bony concavity and increased slope inversion that was gradual from superior to inferior. So anteriorly, it's really like a cliff, like that glenoid is cut off. This is more sloping bone loss. So you can see here in this picture, in this image on the bottom right from 2005, that's what anterior bone loss looks like. So you have that along the axis of the glenoid. It's the same axis as the longitudinal axis of the glenoid. But in this picture on the CT scan above, you can see it's 30 degrees off axis. And it's nearly that whole quadrant from 9 to 6, and it's sloping. So it's a different location. It's a different angle than anterior bone loss. So it's a unique pathology to anterior. When you're comparing directly, there's a nice study from JSES by Preventure's group where they matched 30 anterior and 30 posterior, and again, more granularly showed that posterior had a greater retroversion, anterior was a steeper slope. They had higher percentages of bone loss, and really, again, when it's matched, this has been shown to be true. It's sloping off axis versus more significant bone loss and more along the axis of the glenoid. So when do you care about posterior bone loss? So this is a nice study by Brett Owens and John Dickens and AJSM looking at 1,400 military patients that basically every cadet had a baseline MRI on the bilateral shoulders, and they looked at all of them, 0.7% had a first-time posterior shoulder instability and 0.2% had recurrent. So 11 of these 13 patients had some type of bone loss or dysplasia. And I think that's sometimes difficult to determine. We talk about bone loss, but it may be more dysplasia. It's that posterior portion just didn't develop right. And are they at risk for developing instability just due to their glenoid morphology rather than it being, a traumatic or repetitive trauma leading to the bony change? We don't really know that. But I found if retroversion was over 10 degrees, there was a higher glenoid bone loss. So they were set up to have more bone loss with more retroversion. So the average bone loss with first-time instability was 5%, and average glenoid bone loss with recurrent instability was almost 17%. So this is a small number of patients, but a really interesting study with a whole cohort that are followed pre and post-operatively. So a pretty interesting study. We may be misled. This is a nice study from Preventure and Dr. Romeo that looked at CT scan and glenoid bone loss, and we did the same in one of our studies, which I'll show you. But if the MRI or CT scan isn't taken along the axis of the glenoid, you really can think that glenoid bone loss is less or more, just depending on how the MRI or CT scan is done. So it's sometimes difficult to really know. So we know the known failure rates for anterior, 25%. Preventures talked about 13.5%. Some of the other studies, what about posterior? So this is a study by Brett Owens' group that was 11 cadavers. They basically did along the axis bone loss. And this is before Preventure described that the bone loss was a little bit sloping and different than this study evaluated. But it's a great study looking at 10, 20, 30, and 40% bone loss. And basically, when they got to 20% bone loss, that labral repair, which you can see on the bottom right picture, did not restore the stability. So they picked, maybe 20% to cut off. And this is a study that was run by Bob Waltz that I was lucky enough to be involved in. That was 10 cadaveric shoulders. And basically, we utilized a more clinically applicable type of bone loss just from the more recent knowledge. So small percent we determined to be 7 versus 28%. And those are from these big studies that we've evaluated, basically some cutoffs with regression analysis. So there were a lot of different states, basically normal shoulder, labral tear, repair, small amount of bone loss, then repair, large amount of bone loss, and then repair that. Labral repair did improve stability, and not surprisingly, more bone loss led to more instability. So in the small bone loss group, which again was 7%, labral repair may be enough, but in a large bone loss, do we need to do something else? Basically, there was significant instability just with labral repairs. This is a study from 2020 by Dr. Dickens' group, 66 shoulders, 15% reoperation rate. This was followed up at 16 months, and 86% of patients had bone loss less than 35%. I'm sorry, 13.5%, 14% had more. So they just chose this number. They found with more retroversion, there was more bone loss. So they just decided, since with the anterior, someone picked 13.5%. So if 13.5% bone loss, then 44% reoperation rate. So is 13.5% the critical bone loss from posterior, like it's been shown to be in anterior? Well, this is a study that we did in 2020 where we matched 19 failures to 58 non-failures and did advanced MR measurements like those ones that we showed before that Dr. Preventure evaluated. And we did a linear regression and we corrected all those MRIs. So it was an on-FOSS view. So it was an accurate representation of the bone loss. And if there was significant bone loss, 11%, you had a higher failure rate of 10 times. If there was 15% bone loss, there was a 25 times higher failure rate. So somewhere in there is, I think, where we really worry more. This is a nice explanation from the Yellow Journal looking at allografts. When do we do this? So should we do a bone block? I'm not so sure, to be honest. There's relatively high complication rates and high rates of osteoarthritis, and they don't reliably improve patient-reported outcomes based on the studies that have been published. So here's a chart that if you have over 10% bone loss, and if it's a revision, do you consider a bone graft? Over 20% bone loss. That was what these authors discussed. So here are those studies looking at bone block outcomes, a systematic review in a case series. So this was a systematic review by Andy Sheehan, who thankful for a lot of these images and help with these studies as well. It was a systematic review of 17 studies, and most of them were iliac crest. Complication rates range from 0 to 67%, so quite high. The hardware complication rates were higher with arthroscopic versus open surgery. And then here's really one of the few DTA case series from Brian Cole's group. 10 shoulders, 26% had posterior bone loss, and there were 2 complications and 1 with recurrent instability. So this was showing fairly low complication rate, but 20% is still quite significant. So this is an arthroscopic study from LaFosse's group of bone blocks, so 17 shoulders. They looked at version pre and post-op, and they found significant improvement in patient-reported outcomes, and they corrected the retroversion from 17 to 10 degrees, and they found that the humeral head was re-centered, but they did have resorption, much like we've seen other types of grafting in the shoulder, that there was a surface area that went from 24 to 17% at 6.6-year follow-up, and 47%, I think, very importantly, had osteoarthritis. So this study showed improved patient-reported outcomes, and the glenoid was centered, but 50% of those patients had osteoarthritis. So that's concerning. I don't know if it's from this graft, you're trying to reposition the head, or these patients doomed anyway. And that's, again, at 6 years. So on a young patient, that's pretty significant. It's a nice study again. This is an interesting study, again, from Dr. Owens, who's really also led the way, along with Dr. Bradley and Lance Clare and John Dickens that I've mentioned here, that this was 9 shoulders in 4 different states: labor tear, repair, 20% bone loss, and then an osteotomy, and then a labor repair. So they found that repair and 20% bone loss did not restore stability. And when you did a glenoid osteotomy, they had significant improved resistance to dislocation than just repairing the soft tissue. Glenoid osteotomy is, I think, quite a complicated procedure, not something that I'm too interested in doing, and I'll show some more data about that. But how much glenoid retroversion is too much? Again, another study by Brett Owens. This was an AOSSM presentation a few years ago. But basically, they looked at different degrees of retroversion and how much resistance was required to dislocate those shoulders. And a dislocation in the labrum was intact. What happened with 22.7% retroversion? And when you fix the labrum, it really didn't change the force for dislocation from 0 to 15%. But at 25% retroversion, the labral tear decreased the force required by 41%. So basically, the labor repair did help at 20 to 25 degrees, but it didn't make it normal. So basically, with more retroversion, the labrum is more important. Again, about glenoid osteotomy, this study, I think, is really an important one from Christian Gerber and JSES. So this was 7 shoulders that he did a glenoid osteotomy on. He corrected the retroversion from 20 degrees to 3 degrees and looked at patient-reported outcomes at 15 years. So patient-reported outcomes, 1 was excellent, 3 good, 1 fair, and 1 unsatisfactory. And 1 patient had a revision with a bone block, but it did not improve pain. It didn't center the head, and everyone had arthritis. So for quite a complicated surgery and a risky surgery, without excellent outcomes, this is something that's not something that I'm excited about doing, given these results and the technical issues with it as well. So what about reverse Hill-Sachs lesions? Hill-Sachs lesions have become a really important evaluation in anterior instability, but what about in posterior? We really don't have much data here. Typically, these are microtraumatic injuries, so the reverse Hill-Sachs lesions are smaller or not really common. But here's a way to fix them that Peter Millets described, that you can use a reamer from the back and basically tamp it up and graft and put some screws across. So in traumatic posterior dislocations or people with large reverse Hill-Sachs, you could try this technique, reverse remplissage, or open bone grafting. So thankfully, we don't have to run into those cases too often. And this is more a recent interest of mine in the literature about what other factors. We talked about bone loss and retroversion of the glenoid, and Christian Gerber really brought to our attention a JBJS article in 2019 that maybe the posterior acromion has an idea. And when I first read this, I was a little hesitant to believe it, but I think it's true. 41 posterior patients were matched to 41 anterior, and then 53 controls. They got perfect scapular Y X-rays on C-arm, which is hard to do, at least in the United States. And they found that a higher and more horizontal acromion was associated with posterior instability. So he said, a Swiss chalet roof, a more horizontal and higher acromion, that shoulder can slide out the back because that acromion is not low enough to hold that head in place, or at least give it some resistance to dislocation. So we repeated this study, and it's an AJSM, did the same measurements, but we used MRI, thinking that would be a more commonly utilized and easier to measure circumstance. So we had 37 posterior, 37 anterior, and 37 for a comparison group. We basically found the same thing. A higher and flatter posterior acromion was associated with posterior instability. So interesting concept. Here's looking at that acromion and then bone loss from Dickens and JSCS. This was 89 shoulders, and percent glenoid bone loss was measured by best fit circle, and did the same again acromion measures that Gerber taught us. And glenoid bone loss was linked to more vertical acromion. So you can see it broken down here that when you had 0 to 13.5 bone loss, there was a flatter acromion and less coverage, and basically got even flatter and had even less coverage when you had 13.5% bone loss. So makes sense. Do you have that flatter acromion so that shoulder can shift out more, and then that attritional bone loss happens, that sloping off axis? I think that's very possible. So here's a study that's in press from our group, 37 revision posterior repairs matched to 37 non-revisions. Again, we did the same measures. We found a greater posterior acromial height with revision surgery. So if they had surgery, does this acromion matter? And it seems like it does. Clinically insignificant glenoid bone loss was seen in these patients. So they weren't 20% bone loss or anything, but the height was different. The tilt and coverage was no different, but a higher acromion was associated with requiring revision posterior labor repair. But can you change it? That's the question. What do you do about this posterior acromion? Acromial osteotomy, I don't recommend that personally. We know relatively poor outcomes with stress fractures and RTSAs. This is a little different pathology because it's probably better bone and it's not a stress fracture, but still that bone is small. This is an interesting study from Brett Owen's group as well. Basically a technique that was described in 2006, about 10 patients that he took a portion of the scapular, took a portion of the spine to basically put on the back of the acromion. You can see here in this picture in the cadaver. Brett Owen's group looked at 10 cadavers, and they took 2.5 centimeter scapular spine autograft and harvested, and basically put it back there, and then did an evaluation with a robot. And they found that this did reduce the posterior dislocation in the cadaver model. Now, I've never done this. A year ago when I was talking with Brett Owens about this, he hadn't done this, so I'll have to check in with him at AOSSM coming up. But an interesting concept. So what do we do with bone loss and retroversion? First of all, arthroscopic repair is very successful. Bone blocks, I think, are reserved for a really significant patient circumstances with significant bone loss. So possibly over 15 or 20% in a revision scennario. How do you fix it? You can do an intra-articular distal tibia allograft with cartilage, as described by Preventure and Millets reported on these, as well as others. You can do an extra-articular graft Since there's no cartilage, take iliac crest autograft and either do it arthroscopic or open. Again, glenoid or craniosteotomy, I think in 2025 are not something that we should be doing regularly, but certainly you could consider in certain circumstances. And then what do you do in osteoarthritis? This comprehensive arthroscopic management procedure that Peter Millitz described a few years ago, basically debriding these shoulders to try to buy them some time before an arthroplasty. And then what type of arthroplasty can you do in these young patients? Some bone preserving, in the future, is inlay going to be bigger and bigger, or these hemis with less metallic, like a pyrocarbon. But doing a bone graft when someone has osteoarthritis is not advised. So in summary, this is a different pathology than anterior. Posterior capsular repair is very successful. Contact athletes in our studies have really shown to do the best. You can grab more capsule and really tighten them. When do people fail the primary surgery? We really think it's when people have decreased glenoid bone width, if you're not using a substantial number of anchors, people that are throwing athletes, females, adolescents, and it being the dominant shoulder. We've really learned a lot about bone loss and retroversion. You can even have bone loss 5% after one dislocation, that large military study. Again, it's different bone loss than anterior. It's sloping and 30 degrees off axis. So glenoid version may matter, but osteotomy, again, is not really the best option. And bony augmentation can help, but it's not perfect. And posterior acromial morphology really seems to be impactful here, but the question is, what can you do about it? So more to come, I think, on that front. And this is an exciting time and interesting pathology. So I'd like to thank you for your time today, and thank all my mentors for all their assistance and opportunity to perform this research and learn a lot about it. So thank you.
Thank you, Justin. Justin, you can stop sharing.
All right.
Thank you, Justin. That was a comprehensive review on posterior shoulder instability, and congratulations for all the wonderful work that you do at Pittsburgh.
Thank you.
Justin, let's have a short Q&A. Now,
Great.
Justin, you mentioned in the last slide, posterior instability is actually quite common, right? But if I ask my residents and if I ask my colleagues, they would say, okay, they see anterior, they see multidirectional, they see habitual. But if you ask them specifically, do you see posterior? They say no. Probably they're not aware about a posterior shoulder instability. And so I just want to know, what are the key symptoms that you can look for to pick posterior shoulder instability?
Yeah, I agree. I think those studies that I showed at the beginning regarding the commonality of this, those are patients that have surgery and who has a tear in the posterior shoulder. But I do think it's more common than people think. I agree with you. I think it's just overlooked, and it's easy to overlook even for the patients. They just have shoulder pain. They deal with it. If you get an MRI, sometimes it's not so obvious. You can have that hidden Kim lesion where even intraoperatively, if you're not looking closely and you don't use a probe or evaluate it closely, you can have a split in that labrum or an issue with the capsule that really is pretty easy to overlook if you're looking elsewhere in the shoulder. But clinically, I think you have to look at the right patient and the right history and story. So, I think the classic, as I mentioned, people that are really big weightlifters or military people or people that do a lot of pushing, or, say even simply like, I can't push open a door. It hurts whenever I'm pushing open a heavy door, or physical examination, I think is really important to lay them on their back and do a posterior load and shift. If you feel that click or they have pain, but I think it's difficult to sometimes evaluate. And sometimes we have to, put them through extensive non-operative treatments before we really can dial it out. But I think the real thing is that, a lot of people are labeled as impingement if they have pain. You do an O'Brien or a Hawkins, or they have pain, so they have rotator cuff impingement. I mean, that's something that's pretty rare in a young person. So I think you have to look at the age. Someone that's 20 years old probably doesn't have rotator cuff impingement. Maybe it's a posterior labral tear if they have no significant trauma. So it takes some time.
And I think the best way is to stress them posteriorly, right?
Yeah, I think so. I think a lot of the combination of tests, much like other issues in the shoulder, so a supine exam with a load and shift, or the Kim and jerk test, or those examples of the ones that John Conway and Dr. Bradley described, like this D-pit test and the Whipple test. I think using all of those along with the patient history is most important.
Yeah, there are a lot of tests described, the crank test, the jerk test, so many. I think it's a combination of tests and the right symptoms that can help you pick a shoulder instead posterior one. And the indications also as well, right? You said difficulty in pushing the door, even that could be symptomatic. And when do you actually think, okay, this guy really needs surgery, he cannot be treated conservatively?
Yeah, I think you have a whole gamut, just like you were alluding to. You see some people that I think with the muscle forces, they're so unstable that even lifting their arm to pick something up, their shoulder will slide out the back. I do typically send these people to therapy, but some patients, it's clear that they're so debilitated that there's not much they can do. And other people, you're surprised. Like I had a baseball player that had a single posterior instability event when he was sliding, head first, and his shoulder got pushed down. He's basically asymptomatic after a little bit of therapy. So I'm not pushing them to surgery, but I think just really after these non-operative treatments, if they can't do what they want, that's when we pull the trigger.
And Justin, regarding Professor Christian Gerber's paper on acromial morphology, right? The traditional paper on acromial morphology was with Loiy Bigliani, the bend, the curve, and the hooked acromion for as a predisposition to rotator cuff tears. So, is this a different way to measure the acromial morphology? Because the traditional Bigliani's way, everyone knows how to measure the morphology of acromion. So in Gerber's paper, how do you actually measure the risk factor, acromion morphology?
Yeah, good question. I should have described that a little better, but basically the way he described it was a perfect lateral C-arm X-ray. I think that's hard to do, at least in our practice. So I think if you get an MRI with a sagittal and find that en face view and pick the center of the glenoid and draw, a line basically down the scapula, you have to switch the cuts. Obviously, they're in different planes. You draw that vertical line, and then I think the most important ones are how high the acromion is. So basically, a tangential line to where that acromion, how low it goes, and then you can measure up the vertical line and then down, which is angle. They're all kind of indirectly measuring, the angle and height of those. He also looked at, anterior coverage and height in a different way, where you make a right angle and then the millimeters of height. So I think just that gestalt, if you start looking at it, you'll realize, wow, that acromion is much more vertical or lower versus some of these that are like that. If it's like that head, I guess you don't have that soft tissue barrier between it, and there's less resistance to dislocate. You get more glenoid bone loss, and that's what Dickens' group showed as well. So pretty ingenious from Professor Gerber, which is no surprise.
Thank you, Justin. Justin, we also joined by Loiy. Loiy Al-Khatib is an orthopedic surgeon based in Dubai, prolific orthopedic surgeon. Loiy, welcome to the show, and your questions to Dr. Arner, please.
Hi, Justin. Thanks a lot for the great topics and well presented talk about. It's not a common topic. It's not something that we talk about daily. I think this posterior shoulder instability is something that is underdiagnosed rather than overlooked. This is underdiagnosed condition. But maybe, Justin, you can tell us more about. You touched it a bit. Is there really in clinical exam a difference between shoulder pain due internal impingement, especially in overhead athletes, and posterior shoulder instability? What things in clinical exam, or there's a certain clinical exam that you rely on to differentiate between both entities?
Yeah, that's a great point. Internal impingement, I think, is difficult, and I think there's so much overlap, which again makes this difficult. I think classically, the slap tear, which can commonly be associated with posterior instability too, where it tears down into the labrum. But I think it's hard. MRI is not so helpful. Obviously that abduction external position, if you get them in that, you have to really take a minute. Is it painful from the rotator cuff getting pinched between the glenoid, or is it, apprehension from an anterior labral issue? So I think that's probably the main thing. If you get them an abduction external rotation and they're not having instability, but it's cuff versus that load and shift. But I think it's very difficult. You're totally right.
Yeah. That's why the next question is regarding MRI. Good point, what you see. We usually do a static MRI. Do you think there's a rule for a dynamic MRI, dynamic studies that can show us some labral damage, some posterior instability in dynamic MRIs?
Yeah, I don't have much experience with those dynamic MRIs, but like UCSF and others around the world have really done a nice job with knees and other shoulders. It would be interesting to look at. I think an ABE review, abduction external rotation, is really essential in these young patients to get an MRI with that shoulder up above. And I think that's a way you can see internal impingement sometimes. That superior labrum is falling off the top of the glenoid, that rotator cuff may be pinched in there, maybe inflamed. But I think intraoperatively is probably more important. I do lateral position, but you take their arm out of that traction and put them in abduction external rotation. And I just did a lady, I guess this was last week, that you can see that rotator cuff invaginated in there. It's just all red and beat up. She just couldn't progress with therapy. That was a internal impingement situation, and she had the clinical examination that kind of fit with that. But dynamic MRI, I think, would be interesting. I'm not familiar with that too much, and I would think it'd be somewhat complicated. But the ABER images on MRI, I think, are really essential.
Yeah, great point. So maybe one comment from you to our colleagues here regarding the portals placement. Which portals you prefer to see, the posterior labrum and your walking portal, viewing portal, and so on? I think this is something we can share to our colleagues, to our audience.
Yeah, I like to start with that standard posterior portal, and except I move that about a centimeter more laterally. I think that insufflating the joint is something that Jim Bradley taught me is helpful. I didn't do that initially. Taking a spinal needle and filling up the joint, that blows the balloon up. So instead of trying to put that angle, your capsule sometimes is so floppy. Even if you're angling this way and you catch it at a different angle, or you're trying not to hit the head and then you're angling up and you're fighting yourself to get low. I think if you insufflate the joint, that balloon has more tension. It's easier to get into the joint, probably less traumatic. You have that angle of attack that's a little more vertical to the glenoid to put in anchors. And I'm a big fan of the 7 o'clock portal. Matt Provencher really, in my fellowship, drilled that into our heads, and I think it's really helpful and something not everyone is familiar with. If you take that corner of the acromion and go about 4 centimeters directly inferior along the shoulder, it's a little bit awkward when you first do it. And then I like to do a kind of a cannulated technique with a switching stick and then a nitinol wire and exchange that for a drill guide or a cannula. So then it's straight down towards the floor. So it takes some getting used to, but you can directly look at it. And that gives you such a nice opportunity to put an anchor at 6 o'clock. Some of these curved drill guides, I think, make that portal less necessary in certain circumstances. But I think you should be brave to reposition your original cannula if it's the wrong angle. I didn't want to do that when I first, was starting practice. You don't want to make all these holes in the capsule, but you can't get your guide down there. You can't get your passer down there. So pulling that, put a switching stick in, where your cannula is, back it up, and then find the position you want, and you can close that other one with the PDS. I think those are really, really helpful.
Awesome. Thanks. Great points. My maybe last question regarding the overhead athletes or hyperlax patients. Let's talk about the hyperlax patients. Do you have a special approach for these guys, or do you do something different than the overhead athletes?
Yeah, it's such a difficult situation. I think that's one of the most difficult discussions we have. I had a discussion this week with a girl. Obviously we all talk about therapy, more therapy for months and months. But some people can't progress, but it's hard for me to do a surgery on someone that has a tear. You got a 90% chance to get better, and then these lax people are just not as happy. So the Geigy sign with hyperabduction, extensive external rotation, the sulcus sign. I think you really have to parse those out and not miss those. Thinking someone has posterior instability when it's multidirectional instability, which is obviously really common. So therapy and more therapy, focusing on those periscapular muscles. There's some people talk about, and I'd like to become more involved in this. I think those surface EMG evaluation for especially the periscapular muscles in these MDI patients to show them and educate them. You think you've done all this PT, but you're still winging back there. I still think really doing non-operative treatment in those patients is best. And I just when you get in there and you start putting anchors in and you're tightening up the capsule, it's easy to do, but how is that going to heal and stay normal? It's really difficult.
That's it will be painful for them. They won't like it, actually. Definitely true.
Right.
True. Just one last question. You showed different numbers regarding the posterior bone loss and when to augment. For you, what's the cutoff value for the bone loss that you use the bone augmentation? And when you use the bone augmentation, would you still use it for the high risk patients, even if there's a minimal bone loss?
Yeah, for me, I think I'm less aggressive with that. For me, I would really basically never do a bone, never say never, but a bone block in a first time surgery, unless there's just a fracture or a fracture non-union. But I think these arthroscopic surgeries are quite successful, actually. Getting that labrum and capsule plicated, I think most do fine. I would reserve it for a revision scenario and probably over 20% bone loss, and really making sure that you do extensive non-operative treatments. Brett Owens shared a story with me one time in one of the ICLs we did, that he did a great posterior repair. The patient still had pain. Wanted to revise it, still had pain, and he's like, should I put a bone block in this guy? He has no bone loss. And talking to a lot of his colleagues, he did this surface EMG, showed, wow, you're still just, even though you've done so much therapy, it wasn't adequate. And then with the right therapy, he was able to avoid surgery. So I would really reserve those bone blocks for extreme situations, because they're not benign. Getting in there, you can have great pictures, great videos for presentations, but if they get arthritis in 6 or 7 years and it's a 20 or 30-year-old person, have you really done them a favor? It's a tough problem.
That's game over. That's true. Thanks again, Justin. I think that's it for today.
Thank you, Justin. I think that's all the questions that we have for this session. Thank you for this wonderful presentation. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in.
Thank you for the opportunity. Appreciate your time.
Thank you, Loiy.
Thank you. Cheers.